The broadcast is now starting. All attendees are in listen-only mode.
Good day. Welcome to our webinar. The Global Institute for Simulation Technology and Education Management Solutions are happy to serve as your hosts for today's presentation. It is entitled Interprofessional Education, Challenges and Solutions. We're honored to have as our guest speaker, Dr. Mark E. Servis from UC Davis School of Medicine. My name's Chris Qualtieri, and I'm one of your hosts. Lori Kearns and I serve as your hosts for these webinars. A few of our preliminaries. On your computer, you'll see a GoToWebinar panel. The red arrow should let you open or minimize your control panel. And during the presentation, you'll have the opportunity to send us questions. We do want you to participate even though you are in listen-only mode. So you can type in your question and hit send. At the end of the presentation, we are going to address as many questions as we have time for. If you're tweeting about this webinar, you could use the hashtags GISTWebinars or EMS webinars. Today's webinar, as always, is being recorded. And within the next few days, you're going to receive an email with a link to the recording as well as the slides. We invite you to provide feedback about the webinar and complete a brief survey at the end of our session. It will open automatically when you exit. So now let me introduce our speaker. Dr. Mark E. Servis is a Vice Dean for Medical Education, and he leads the Office of Medical Education at the University of California, Davis School of Medicine. A general psychiatrist with training and experience in consultation psychiatry and medical and surgical specialties, he has expertise in personality disorders, integrated and collaborative care, and psychodynamic psychotherapy. During his tenure as Senior Associate Dean for Medical Education, Dr. Servis led the development of a new and improved set of graduation competencies and associated milestones to guide the School of Medicine's curriculum, pedagogy, and student assessment. He coordinates the School of Medicine accreditation efforts, and that included a historically successful LCME site visit and 8-year accreditation achieved in 2014 with 4 areas of strength. He's an expert in integrating psychiatric care with primary care settings, and Dr. Servis has pioneered combined residency training programs in family medicine and psychiatry, and internal medicine and psychiatry. So Dr. Servis, thank you so much. We are glad to have you with us today, and I will make the presentation on your computer. So let me turn that over, and we'll let you know when we can see your slides. Okay.
All right. Well, thank you, Chris. That was a very generous introduction. And I'm going to be sharing largely from our experience here at UC Davis in pioneering interprofessional education in our curriculum across several schools. I'll be speaking mainly from the medical school perspective, as that's my primary role as Vice Dean for Medical Education. And we've done interprofessional education with the nursing school here at Davis, the Betty Irene Moore School of Nursing, and also with our partners in pharmacy, social work, a veterinary school on the Davis campus, a law school. And so we have accumulated over the last dozen years some good experience, I think, in delivering interprofessional education, and we've learned quite a bit. And I suspect that's the same for many of you who are listening, and hopefully at the end we'll be able to ask questions and share experiences together that we can all learn from. So why interprofessional education? I think more than likely this is something that you've already heard, but there are several drivers, I think, that have led health professions to focus on the need for interprofessional education. One of the early focus or emphases in interprofessional education was on patient safety and quality improvement, and really looking at the importance of team-based approaches to healthcare delivery that would ensure greater patient safety and better delivery of care. And not surprisingly, within health professions education, there was the development of interprofessional education competencies. Within medical education, those are largely within the systems-based practice competency framework, and often focus as well on those QI and patient safety issues. But there's also been nationally the development of specific interprofessional education competencies across health professions. And the AAMC in medical education, the AACA in nursing, AACP in pharmacy, dentistry, public health have all come together and have actually produced nationally a set of IPE competencies, which are aspirational for us, I think, in delivering effective interprofessional education. And also, of course, I think a large amount of interprofessional education is focused on workforce development. The fact that we're not able to deliver particularly primary care to a chronically diseased population, an aging population, where we know team-based care is particularly important. And as well, it's a, I think, important initiative in driving down healthcare costs, which are such an important part, I think, of the future for us in healthcare delivery. So for all these reasons, interprofessional education is something that I think we're all trying to do. And we have some nice competencies and milestones to guide us in those efforts. So I wanted to ask those of you who are listening to get a sense of your experience. How would you characterize your own efforts to implement IPE? And the answers here are: we haven't done it yet, we're just thinking about it. We're in the early stages of implementation, we're just starting out. We've tried interprofessional education and it was easier than we thought it would be. We've tried interprofessional education and it has gone as we expected it to. Or we've tried interprofessional education and it has been more difficult than we thought it would be. So let's see what our listeners think about these.
I'll give it another 2 seconds or so. We have a good response coming in. About 70% of our audience has voted. Okay, so I'm going to close the poll now. And the responses that we have say that 32% have tried IPE and it's been more challenging than expected or more difficult. 26% say early stages of implementation, just starting out. 19% we've tried IPE and it's gone as expected. 17% not yet, just thinking about it. And then a small number, 6%, have tried IPE and it's been easier than expected.
Great. Well, thank you, Chris. And I'm not surprised by those numbers. I think I would put our own experience in the category, the one that was most frequently selected in the poll, that we've tried IPE and it has been more difficult than expected for us, which is part of what I think has led me to think and teach and write about this a bit, because I think we have learned some things from our experience. I'm really interested at the end to hear from those who have found it easier than expected, and maybe you could teach this a webinar the next time and give us the secrets to your success. And then it does sound like there are many who are just really beginning this process, so hopefully this will be particularly helpful to you, what we're talking about today. So thanks everyone for your responses to that. So as mentioned, we have all these good reasons to do interprofessional education, but as I just shared, our own experience here at Davis has been that it has been more difficult than we thought. And I'm going to talk about what I think are some of the common challenges that have made it particularly difficult. to do good interprofessional education. And I would say that, if you look at efforts to merge what I would characterize as complex cultures, which I think we have in health professions schools, there are often major conflicts that arise when bringing cultures together. And I'm sure you're all familiar with the quote that organizational culture eats strategies for breakfast, lunch, and dinner, that it is often very challenging to bring cultures together. A couple good examples for us locally here in Northern California. Several years ago, Stanford and UCSF, two of the larger academic health systems in our region, decided it would make sense for them to merge their clinical operations and to together work collaboratively to provide really impressive and wonderful healthcare delivery system. But that effort, which got a lot of fanfare and people were very excited by it, ran aground as the two cultures just collided. And within a couple of years, that initiative died completely. And as mentioned in the introduction by Chris, I have our own experience here at Davis. We do combined residency training and graduate medical education that we've pioneered, merging psychiatry and both internal medicine and psychiatry and family medicine as residency training programs. And we have found that those approaches are in fact challenging because of the very different cultures, even within medicine, between those departments. So I think this sort of anticipates some of the things that I'm going to be sharing with you as we talk about these challenges. And so just to give you an overview of the framework that I'm going to be talking about challenges in when it comes to interprofessional education, we're going to talk a bit about psychosocial challenges, cultural challenges, things that we might characterize as culturally based, logistical, pragmatic challenges to interprofessional education, and finally, deep structural or systems-based challenges. And I'll talk a bit about each of these. So to start off, I'd like to focus on the psychosocial issues. And I think one of the things that we often underestimate or don't think about that relates to a challenge in interprofessional education is that our own health profession students are undergoing their own professional development. And as a result, I think there are some ways in which that process interferes with some of the things we like to see happen in interprofessional education, as our students are still pursuing their own professional identities. And more, at least within medical education, we see our students coming in without much of a concept of what we would typically think of as professionalism in medicine. And so they're at a very, very early stage, and it's a developmental process for them. And they're typically seeking out faculty role models, a lot like adolescents do developmentally, as they sort of try on identities. And by and large, I think the health profession students pursue the role models within their health profession faculty. And in emulating those role models, I think that is the process of professionalism and development that's underway. And in that process, they're actually learning about their profession. And that process is an interesting one. One of the things we've seen when we've done interprofessional education here at UC Davis is when we brought, for example, in our first year, we've combined taught physical exam to both our nursing students and our medical students in small groups. And when we first brought them together, it was a bit of a surprise to us that the medical students didn't know the roles of nurses, that was something that actually had to be explained to them. Likewise, nurses weren't entirely clear at an early part in their education as to the specific roles of the physician. And so, again, defining roles and practices for themselves and for each other in interprofessional education seemed to be an important step in the process. But what happens, of course, is that the students really are looking in that development of professional identity to connect to a group, and they tend to cluster naturally if you don't intervene within their own schools with their own health profession peers and not across schools. And so we think this, again, establishment of identity is an important developmental and necessary process for them, but it's working against, at least in these early stages of education, some of the things that we like to see happen in terms of connecting to and relating to other health professions. And finally, I will, my nursing colleagues are constantly reminding me of this phenomena of MD exceptionalism, a tendency to elevate MDs over other health professions, which works against, I think, effective interprofessional education and is deeply embedded in some of our school cultures. Other psychosocial issues, as mentioned, I think our students are struggling with their own development. Again, if you think of stages of human development in Erik Erikson's framework, you probably remember that young adults, certainly adolescents, are struggling with their own personal identity. And so identity is a very central issue, I think, for young students, given their ages. And on top of that, I think health profession students, and maybe particularly medical students, tend to be a very controlling group. And what this means is that they're perfectionists. They have obsessive compulsive personalities often, or at least features of obsessive compulsive personality. They have very high standards. They don't like failure in themselves or others. And this is a challenge when you put them in teams and you're trying to get them to work collaboratively. They prefer to control their learning, and when they are reliant on others, there's that dependency. I think it's a challenge to them. A good example of this in our own experience with students is, when we use team-based learning, we have students doing IRAD and GRAD exercises where they answer questions as an individual, and then they answer the same questions that they answered individually within a group. And every year I have students who tell me, well, I'm going to do better answering the question individually than I will within a group, what the group comes up with as the answer. And our students, that's their default thinking. They think they'll do better as an individual, when the statistics are clear. The group responses are more accurate, they're better. And yet this is the kind of psychological framework our students are bringing, which tends to keep them operating on an individual basis. And finally, I want to comment on the challenges of developing teams, and a large part of interprofessional education is focused on developing those team-based skills. And as you're all familiar, group dynamics of teams, of course, are often very challenging. We have found this consistently in our interprofessional education efforts. The one lesson that I'll share now that we have learned is, whenever possible, when we have students in a group from different health professions, that we love to have co-facilitating leaders, faculty from both schools, and that seems to help with the challenging group dynamics. Working groups are very fragile, they're easily disrupted. We just had a session, I was looking at the evaluations that we recently received on an interprofessional education piece of our curriculum. Again, this is in the first and second year, where we actually teach culture, diversity, cultural competency interprofessionally with nursing students. So the small groups that are focused on this cultural competency curriculum have nursing students and medical students. And many of the groups had, in the most recent session, I was reading the evaluations, had wonderful learning, good experiences. But we had a couple of groups that went very poorly, and largely because there was a group member with an axe to grind that was, in one case, it was sort of an anti-MD mentality. it can be very challenging for the group facilitators to manage a group effectively in those scenarios. So that is something that we've certainly run into. Keeping the groups working well is an ongoing, challenging process. It's very important to do faculty development with the group facilitators to minimize the regressive and destructive elements. And in group dynamics, we talk about some of the things that can happen in dysfunctional groups. There can be pairing where group members sort of join up for support and often create sort of subgroups within a group. And that can be very difficult. When we've taught our physical exam with nursing and medical students, and you ask the students to pair up and do parts of the physical exam on each other, they always pair up in default with peers from their own school. And so we've really encouraged them to cross over and not pair in that way and to work with a peer from a different school, in our case with the nurses. And but you also get splitting and scapegoating where, you know, if the group is regressing, it will attack often one of the members or even sometimes the group leaders. Externalizing, of course, is very common, taking whatever conflict or aggression might be simmering within the group and targeting outside forces, institution, authority figures, etc. And finally, some groups regress to a kind of over-processing of everything that's going on, and as a result, don't get much done. So these are all the sorts of challenges we see when you do interprofessional education, and I'll talk later about this. The pedagogy we're most frequently trying to utilize because we think it's the most effective in achieving interprofessional education competencies is small group-based efforts. So these group dynamics become very important. So I want to speak again about another piece, I think, of the challenge in interprofessional education, which are cultural issues that come up. And this is culture broadly defined. I think one of the things that's true in health professions is, by and large, we have curricula that promote individual accomplishment versus working in teams. And if you think about the way we evaluate and grade, it's almost invariably of the individual and rarely of the team itself. And so our curriculum itself is set up with an evaluation process that promotes individual autonomy and effort versus the work of a team. And so if you combine that with the developmental issues, psychosocial issues we were talking about earlier, there's a strong cultural push here to work individually and against the kind of team-based work which we think is central to good interprofessional competency. And if you've utilized peer evaluation in health professions education, you've probably seen this, that getting peers to evaluate each other, even within a health profession peer group, is very difficult. That by and large, the learners are reluctant to give any kind of negative evaluation of peers. There may be, we've seen a little less reluctance of giving negative evaluation across schools. So it does appear in interprofessional education settings, we can get them to be critical of the health profession students often in the other school, and then more protective of their own peer group within their school. And this just speaks again, I think, to the very strong cultural and in some respects psychosocial effects that we're always working against, I think, in getting effective groups and teams. I think you all are aware that in certainly in medicine, it's very hierarchical, top-down, sort of social dominance. There are structural toxicities in medicine that work against a culture that promotes team-based approaches. and collaboration in the best sense. And I would say there's probably an overarching Western value at work here that focuses on individuals and autonomy and self-sufficiency. It may be a heritage of the Puritans. And one of the wonderful things about diversity in our health profession students is sort of diluting that Western value and introducing other cultures and perspectives that are more collective and collaborative. But of course, the American culture for most of us is the dominant culture we're working within. And again, there is promotion of individuals and of individual autonomy versus working collectively. And finally, I do think, professional values that we are trying to develop in our learners tend to assign responsibility to the individual, that individuals act as professionals, not collectively as a team. So that we even tend to teach our professionalism in that way. So these are some cultural issues. Here are a few more. I thought I would bring in the fact that when you look at healthcare delivery, even in the media, there tends to be, I think, a elevation of heroic solo efforts rather than collective team efforts. And our students are all familiar with House, Grey's Anatomy, and other shows where I think they're getting, it's probably naive to underestimate the potential effects of media on our students thinking about these issues. I have in recent years had some rethinking about, we have what's called a white coat ceremony. I think most medical schools are doing this these days, and it's really an attempt to give first-year students at the beginning of medical education a sense of their professional development and getting them started on that pathway. But I think some of the messages inherent to our white coat ceremony, where we make our students feel like they are in a special category and are on their way to becoming the physician they will be in the future. And very appropriately, I think this is trying to promote professionalism, but some of the culture in that process may be working against what we are trying to do in interprofessional education. And then by and large, our faculty are not particularly skilled at interprofessional education, or even in effective leadership of teams, or even as participants in teams. This was not part of their own education or training in medicine. Certainly it was my experience many years ago in medical school. I can't even remember ever working or learning interprofessionally. I did get to see, and this is, I think, important to try and maximize within the experiential training that our learners get, exposure to effective teams and interprofessional care that sporadically showed up in my clinical rotations. Here at UC Davis, the best resource we found for gaining the right kind of exposure to interprofessional care has been in our rural training sites. We have a program here at Davis that is particularly focused on training physicians for rural settings. And boy, our rural physicians are probably our best, or some of our best clinicians at delivering team-based care and working collaboratively. So to sum it up in a way, the cultural issue, the lone doctor model, I think, is very deeply ingrained. It's what I think we'd characterize as part of the hidden curriculum that we're dealing with, and therefore is a challenge, I think, to doing good interprofessional education. So now I want to talk briefly about logistical or pragmatic issues that come up with interprofessional education. And these are the ones you probably hear about the most in talking with colleagues who are trying to do this in their own institutions. And this is one that invariably gets mentioned. And this is the fact that when you're working across different schools and sometimes different institutions, there are invariably very challenging scheduling problems, calendar issues, when you are trying to co-locate, temporally at least, your learners together. And every time we've launched an interprofessional initiative here at UC Davis, we've had to do it far in advance of our anticipated delivery of that, because of the need to change the calendar such that we can pull it off. And so this, it seems very pedantic. I can tell you, as I mentioned at the outset, we do interprofessional education with the nursing school here at UC Davis, but also with the vet school, the law school, with our pharmacists, with social work students, and trying to coordinate 2 or more calendars to do good interprofessional education. Unless you're doing it in the evenings, which nobody wants to do, it's just really very difficult. And as mentioned, we work across institutions, or even here at Davis, we have a medical campus, health professions campus, where the nursing school and the medical school are in Sacramento, but the vet school, the law school are in Davis. It's a good 40 minutes away. And so not having our students or our faculty being co-located just adds to the challenge of doing interprofessional education. Similarly, I don't think our information systems and sometimes our educational technology may be siloed and not integrated. We're fortunate here at Davis that the nursing school and the med school use Canvas as a learning platform. We use MedHub. We share some systems, but when we cross over to the vet school, they're in an entirely different technology world, or the law school certainly, or social work. So coordinating across those systems is another very pragmatic logistical challenge. I also want to say I think it's maybe particularly difficult, given the nature of pedagogy with online curriculum, that it may be, and we're still looking for creative solutions to this as we continue to do more and more of our education online in flipping the classroom and other initiatives. It's harder, I think, in general, to adapt good interprofessional education groups and team-based teaching to an online delivery. And finally, I'm sure this is one that's universal to all of you. It's harder and harder to find the time that is needed in an already overcrowded curriculum to add interprofessional education competencies to the curriculum. And I think this is a challenge whenever we're trying to modernize and add in new competencies that we think are important to future healthcare. So I've got some structural challenges. Finally, I'll finish with these. These come up, I think, as well. One of the things that we've seen very pragmatically in setting up interprofessional education is that we have learners that have widely varying backgrounds, and they're at very different levels. And sometimes when we've brought them together, we've not done the best job of matching them at the right stage appropriate level. To represent that challenge here at Davis to you, I can tell you the nursing school here has bachelor's level degree programs, master's level degree programs, PhD level degree programs, and they have a physician assistant program where, by and large, the physician assistant training here at UC Davis is utilizing, those students have a wealth of clinical experience before they start their formal PA training. Many of them have served in the military as medics. They have actually some very interesting backgrounds. And so when you bring all these different learners at different stages together, we've had to do some course corrections in recognizing they're not at the same stage-appropriate level for what we wanted content-wise to deliver. Other structural issues, I think you're all probably in institutions that have silos, that within medicine, we're largely a department-based structure, and then the schools themselves are often siloed from each other. They have separate leadership that are trying, I think, more and more to reach across schools and collaborate. But structurally, I think academics is still challenged to do that as effectively as it needs to. There's often very different funding streams that support education, and how do you negotiate the support for interprofessional education across institutions. In our experience, I think it's important that each participant have a stake, meaning they are contributing in some substantive way, that seems, in our experience, to correlate with some degree of success. But the overall silo mentality of academia does work against us. So I've talked about a lot of challenges here, and I'm interested in hearing from the listeners. In your own experience, which of the challenges that we've talked about is the most frequently encountered barrier that you've had? And this will apply, of course, only to those of you who've really launched some effort in IPE. So in your own experience, what is the most frequent barrier that you've found? Is it in that psychosocial domain, or would you characterize it as cultural? Is it that logistical barriers that we've discussed, or the deep structural barriers?
And the poll is open and active, so I'll give everyone another 5 seconds or so. Looks like logistical is the most frequently seen problem or concern. We have, of our audience now, we have 63% who say that logistical problems are the issue, 14 for both cultural and for structural, and then for psychosocial, about 9%.
Very, very interesting. You know, I think that in our own experience at Davis, and I think I mentioned this when I was discussing those logistical pragmatic challenges, every time we have done interprofessional education, those have come up for us. So I do think in terms of frequency, that is not a surprise to me. It's certainly been our experience as well. And when I talk with colleagues across the country, it comes up again and again for all of them. We all have these wonderful goals to do interprofessional education, and then we have this very pedantic, pragmatic issue of getting everyone's calendar coordinated that just comes up again and again. I have another little variation on this question that I was interested in hearing from those of you listening to. Again, I think it's really interesting to hear people's experience. Which of the challenges that we've talked about do you think is the most difficult to overcome? So of these large categories of challenge to interprofessional education, in your own experience, what's the most challenging challenge? What is the most difficult one to address?
And our poll's open. I'll give you another couple seconds to vote. In terms of the challenge that might be most difficult to overcome, right now it looks like cultural and logistical are the two biggest ones. So as I close the poll and tally the results, we have 40% cultural, 32% logistical, 21% psychosocial, and 7% structural.
Very, very interesting. More of a general distribution there across these challenges, which is not a surprise to me, as I think, you know, we talked about that quote that organizational culture eats strategy for breakfast, lunch, and dinner. I do think the merging of cultures is perhaps the hardest challenge to overcome. I think that I would probably have selected cultural for our own experience, but not to minimize those logistical challenges that are very real, and the psychosocial challenges as well. So that's, I think, reflective of the fact that all of these have some merit as you think about doing interprofessional education, and therefore are probably important to think about and to address. And so that's exactly what I want to do right now, which is if some of these challenges that we've been talking about are a problem, then what are we going to do to solve them? And I'm going to share some of our experiences and ideas, and maybe in the question and answer time that we have, we'll get some of your thoughts as well. So I lumped together psychosocial and cultural solutions. There's certainly overlap between these categories. And so I thought in talking about approaches, we would just join those together. So one of the things that I think we tried to do here at UC Davis is broadening our role model and professional identity formation, not keeping it so much tightly within schools, and trying to give our students early exposure to interprofessional education before they do develop roles that are too narrowly defined. And as I mentioned here at Davis, we have a nice program in rural medicine that I think some of our most functional and highly competent interprofessional healthcare delivery teams, and giving students exposure to that early on, we think has been really helpful as they see role models who are doing team-based care and are working interprofessionally. And I think that that broadens their concept of what, in our case, physicians do, and then leads to a sort of broader professional development and identity for them. And we've also, here at Davis, tried to get our students to socially connect across schools so that they don't just belong to their immediate peers within their school. They are, a good example for us is we have what are called student interest groups within the School of Medicine, and we have made several of them interprofessional, where we've welcomed in both vet students, law students, even in some cases, the advocacy student interest group, and nursing students. And by making those groups, which are social groups by and large, well, I mean, they're obviously trying to educate and facilitate around particular causes and common interests, but it's an easy way for us to develop connectivity across our schools and between students in different schools. So that's been one thing that we think has been helpful to us in addressing some of these deeply embedded psychosocial cultural challenges. We've also, of course, I mentioned earlier, the interprofessional education competencies, which not surprisingly are common to the different health professions. But in addition, there are some parts of education for us that are particularly, I think, amenable to good interprofessional learning. And I've already mentioned our teaching of the physical exam with nursing students here at UC Davis. We also teach ethics with nursing students here, medical students and nursing students in small groups. We also have, and I think I did mention this too, our cultural competency diversity curriculum is interprofessional, and again, that's with the nursing students. We also teach pain and pain management interprofessionally with nursing, pharmacy, and social work students, along with medical students. And so there's common competencies across those schools when it comes to pain and pain management that we've been able to take advantage of and deliver interprofessionally. And then we're launching here at Davis, and it's actually a UC system-wide effort to address the opioid crisis and prescribing and opioid addiction issues. And we're creating interprofessional education modules to do that. So again, there are some of these areas, common themes, or in the case of the opioid crisis, it's really taking advantage of something we feel like we need to add and do something about, which in talking with our clinicians, they are unanimous in thinking if we really want to address the opioid crisis, that we need to do it interprofessionally. So good examples there of common competencies. Another thing that we've tried to do is share some ceremonies together across schools. And a good example for us is we have joint awards that are given. Actually, some of them are focused on effective teams, and the award ceremonies are, of course, across the schools. And in doing this, we think we break down some of the cultural differences. And then, no surprise to all of you, we're using very active learning pedagogies that we think have effects on some of these psychosocial cultural barriers, because the more relationships you create in these groups across schools in particular, and have students have to work collaboratively as they do in both team-based and problem-based learning, we think this works against those cultural barriers that we've talked about. Finally, you all know that evaluation drives learning, so we have created interprofessional evaluation in our clinical skills evaluation. So we actually use scenarios with standardized patients where the nurse comes in to the room with the patient and addresses the medical student, bringing in some additional information, and the student has to manage that interaction with the nurse collaboratively as well as manage the patient. And so these OSCEs are, I think, important in driving our learners to value effective team-based care and the importance of good interprofessional relationships. Some other cultural psychosocial solutions is, I'm sure many of you are using simulation, and here this is getting typically learners from different schools. We do code training here in our Sim Center, where students are working as a team across schools, across disciplines, running a code. And we find that these simulations, not surprisingly, are powerful learning experiences. And we also try to do role playing where we place our learners, in the case of medical students, we put them in a nursing role, and we put nurses in the medical physician role. And I think a lot of learning occurs if you do really good method acting role playing in that way. We try as much as possible to break out of top-down hierarchical structures in clinical settings and even in education, and share and rotate leadership whenever we can. And we do this not just in clinical delivery teams, but in research or in education as well. We think that that's always helpful in addressing these cultural issues. And we try as much as possible to have a sense of collective responsibility when it comes to patient safety and in quality. And we tried to get quality improvement projects across our schools. A good example for us at Davis is our pharmacists do wonderful QI work, and we've gotten our medical students to be involved in their projects, which I think is a really helpful step. And it's helped as well in broadening the concepts of professionalism that we think we want our learners to think about. Then on to logistical structural solutions. I mentioned this, I think, in talking about the scheduling calendar issues. You just have to do it way in advance and communicate well. And as I've said now a couple of times, whenever we do interprofessional education, scheduling and calendars become an issue. Plan way in advance. Also, because of all the challenges we've talked about, I think interprofessional education is reflected in our first question poll is often harder than expected, and you have to be willing to take risks. And I can tell you here at UC Davis, although we've had many successful interprofessional education efforts, we have also had failures. And so we have, on one occasion, launched an interprofessional education initiative that we ran for a couple of years, and then we just realized it was not working, and the solutions we had attempted had not been successful, and we sunsetted that particular effort. So there could be failure even, I think, when it comes to these efforts, and so be prepared and be willing to take those risks and have the support of leadership to do so. And then faculty development in facilitating groups, and particularly interprofessional groups, and also getting our own faculty to be effective, skilled team participants or leaders are important structural issues. Trying to have partnerships across schools and sharing of resources here. Some of the things that we have tried to do across the schools that I think help to undergird good interprofessional efforts are shared resources when it comes to student wellness, to academic support for students who are struggling with test taking. There's a lot of opportunity to share resources educationally and in information technology. So here at Davis, we share educational technologists with the nursing school and the vet school. We share instructional designers with the nursing school. So there are ways that you can build collaboration, I think, at the highest levels in facilitating this. And also, when it comes to interfacing with the EMR and the teaching within the EMR environment, that's something we share with the nursing school here as we try to build learning opportunities for our students within the EPIC EMR system. And joint leadership is always good. Our earliest efforts at IPE here, I was joined at the hip with my counterpart in the nursing school, Debbie Ward, in trying to facilitate and launch a number of interprofessional education efforts. And the two of us were partners together in this co-leading, and I think that that's an important symbolic framework to use structurally. If you're going to do good interprofessional education, I think it's important to have it modeled right from the top. So to sum up, I'd say the time is right and continues to be for interprofessional education. It's important to our future. And I think the pressures on us that we're all feeling to do good integrated healthcare delivery and address the needs of a chronically diseased aging population, it's a kind of crisis that we have. And I would say, you always want to take advantage of a crisis. And so these issues that address workforce needs and the need for healthcare reform, patient safety, quality improvement, decreasing costs, these are all incentives to do this interprofessional education. So I'm going to stop there, and hopefully we'll have some questions and comments from folks.
We do. Thank you so much for all of that. I did want to reiterate one thing that you had mentioned, and that is that in the first poll, the audience did indicate that some audience members had some success with IPE at their own institutions. So I wanted to invite you to maybe write in the question box some of your own successes with IPE, your secrets to success that you might share with the rest of us. So, Dr. Servis, we do have some questions. We have a question from Carol, and she asks, what's the highest number of groups that you've had participate together in a single event, an IPE event? Now, I would take that as either the number of groups or the number of participants in a single interprofessional event.
So, Carol, that's a great question, and I'm going to guess at what might be the origin of that question, and it's that the early efforts in IPE that occurred in many institutions around the country, and again, I'm a little bit MD-centric here in talking about medical school efforts, but we're often to have what I would call a interprofessional education day. And I think that was in part because those logistical challenges of calendaring were such that the best that people could do is say, well, on this one day, everybody, and of course you'd have to do this way in advance, but every school is going to send their learners for a full day of interprofessional education around some content area. And so when you do that, then you are talking about a large number of groups. You could have 30 plus groups in such a large day of interprofessional education. I will tell you that evolution in IPE that I've seen in the last 10 years has moved away from that as a cornerstone of interprofessional education. It's not that it wasn't effective. I think it was often evaluated positively. But in terms of impact, I think people felt that these were one-off, one-time things that didn't have much sticking power. And so I've seen institutions move away from that day of interprofessional education and moved more towards organic, regular parts of the curriculum, even with all of the logistical challenges that go with that. So here at Davis, that's what we do by and large. We don't have a day of interprofessional education. We have ongoing interprofessional education embedded in the curricula of our schools. And the largest number of groups for us, and it just has to do with the size of our nursing school and our medical school, is around 20, which of course then you have to find, ideally, as I mentioned earlier, maybe up to 40 group facilitators, 2 co-facilitators of each group. We try as much as we can to have both institutional faculty groups represented in each group, because the groups are mixed and generally pretty balanced between the learners.
Wonderful. Okay. I have another question here from Myra. It's often difficult to make sure all nursing students are able to utilize the sim labs and resources. How have you managed when there are multiple disciplines that we're trying to meld, blend, or accommodate?
Well, that's a real good logistical structural issue, I guess I would say. And I'm going to cheat a little bit by saying here at UC Davis, we built 2 new buildings to do just that, both of which had, one is our Center for Health and Technology, and one is a new building that is dedicated to the nursing school. And in both facilities, we ensured that there, particularly in the Center for Health and Technology, most of it is simulation. And so it greatly expanded our physical plant resources for simulation. Until we had those facilities, we had a real crunch on our own sim lab education. And as well, our standardized patient program was not large enough to accommodate both the nursing school and the medical school. So it simply came down to, we had to do the heavy lifting of getting the leadership to fund and support the physical plant resources, the hardware really, that we needed. And I think until we had the additional resources, we're now actually at a point, I was just over in one of those new buildings, and I can say we're not even fully utilizing those resources. We have changed our availability such that we now have a slight surplus, I would say, in some respects. We're not using them as much as we could. We will as we continue to grow and as we continue to add simulation and standardized patient training to our curriculum. But that's a very real issue, and I can only tell you, you have to have the support from leadership for IPE and for the pedagogy that with simulation is so effective in delivering it.
Well, Shari actually has a follow-up to that, and the basic question is, can you give a few tips for improving buy-in for this, for that variety of disciplines, for those leaders?
Yes, well, I think that you have to have education as, a seat at the table at the highest levels of the institution. That's the position that I'm in here at UC Davis on the executive leadership team, so that you've got a voice and an advocate that is in the ear of the leadership. And, I think you also want to promote and look for voices that are going to be supportive of IPE within the institution, are going to be advocates, are going to be people that I think have some degree of consensus building skill to bring the institution around. Given all the challenges we've talked about, it's not going to happen automatically. And so the other thing I would say is that when you do send leaders to the AAMC meeting or other national meetings, I do think they get a heavy dose. I know one of the ways I've tried to influence our dean and the vice chancellor for human health sciences is to send them or make sure they're at those meetings where they're hearing about what everyone is doing in IPE and they get that bug. And that, I think, is a learning experience for them. I'll also say structurally, as I mentioned, we have a vice chancellor for human health sciences position. So if you think about that position, both our nursing school dean and our medical school dean are reporting to that person. And so you can see structurally here at Davis, we've kind of created, I would say, a structure that is helpful in facilitating IPE.
Wow. On that note, unfortunately, we have to end because we've reached our limit, but you've given us a lot to think about, and I hope that when our audience receives the recording and the slides, that maybe they can share this with their leadership and continue these discussions, hopefully. So, Dr. Servis, I want to thank you for your time. Beautiful presentation, and I want to thank our audience for being so engaged. So we want to wish you adieu until 2018, when we will see you again. Have a great day, everyone.